Okay, thank you. So I'm going to talk today about the approaches to behavioral and psychological symptoms of dementia. And thanks for coming, guys. I hear this is mandatory anyways. Because so you're a captive audience to me. So for our objectives, we'll develop a broad understanding of dementia and BPSD. We'll understand some of the non-pharmacological approaches to the management of BPSD and a quick tangent on, because it's an enTECH talk, in technology for persons with dementia. No one pays me to do anything, so here I am. Copyright materials for some course. I forgot to ask Colin what course it is, and I've cited this material. All right, so about me. So I'm from McMaster originally, and I did my undergrad at Waterloo, and now I'm in Calgary, which is an awesome city. This is Calgary in September, and that's my home. This is Calgary in the summer with tumbleweed, and all this is a lie. This was a weekend ago. Colin came to visit me. We did a great trip to Banff and Lake Louise. As you can tell, it's beautiful. People really should not be skating on the ice there. It was quite dangerous, but yeah, to each their own. Awesome. So we'll start with a case. I think it's easiest if we kind of frame it around Mrs. Smith. So she's a 75-year-old female who's been finding it harder to remember where she places her car keys or where her utensils are in the kitchen. And her family's noticed that her house has become more disordered and she's being much less engaged in her local community. So what do you think the diagnosis is? Well, it's a talk on dementia, so chances are she has dementia. However, there are many kinds of dementia, the most common being Alzheimer's. And according to the Alzheimer's Society, 500,000 Canadians have dementia in Canada, and about 25,000 new cases each year. So have any of you interacted with someone who has dementia before? Hands? Yeah, okay. Awesome. Yeah, so it includes family, friends, maybe some sort of volunteer position, and it does affect a lot of older adults. So kind of the physiology of dementia, when we talk about that, there's kind of three interrelated mechanisms, and I'm in no way an expert in any of these. The first one being the most common hypotheses that most of us will know about is amyloid plaques. And it seems that people have a genetic predisposition, and some who produce more plaques or those who have more difficult abilities in breaking it down when they get older. There's also associations with vascular disease. So think of it as like fatty plaques building up in your blood vessels, and you end up having poor oxygenation and delivery to your brain. And that's almost kind of like the same mechanism as a heart attack, where there's just decreased blood flow to your heart, your coronary arteries. And then finally, the effect of aging itself on the brain. So you can kind of group all of this together as essentially brain failure over time. In terms of the brain pathology, starts in the medial temporal lobes before spreading to the parietal and frontal cortex. And I'm not sure how many of you have taken a course in neuroanatomy or psychology, but many of us might recognize like Broca's area or Wernicke's area, and that's kind of all in our temporal lobes. And it would kind of make sense then if you lose that, then there will be problems in your speech. And then if you, right, with the Broca's and Wernicke's area. And then after that, if you have your parietal lobe get affected, you'll have issues with visuospatial sense. And then finally, again, a lot of us probably know that the frontal cortex is involved in, or frontal lobe is involved in executive function. And you can kind of expand on it a little bit further. So certain areas in the prefrontal cortex are involved in planning. Some in the lateral areas of the frontal cortex play a role in control. And then the anterior cingulate, as well as the nucleus accumbens, plays a role in emotions as well, which is kind of more medial to this picture. So all the dementias themselves have very different findings and clinical signs and symptoms, but again, not the focus of today. And then finally, with the neuritic plaques, they contain all the amyloid, beta, and the tau filaments. And there's a lot of genetic predisposition that we think about it, that it confers increased risk for late onset dementia, but a lot of cases are actually sporadic. We can talk about that later if anyone has any questions on some of those autosomal genetic predispositions. So let's kind of use what we've learned so far to understand those clinical manifestations. So if kind of all you conceptualize that if I affect my neurons in the brain, then I'm probably going to have issues with memory because, it's all that the neural connections that help make memories. And then if I affect the temporal area, then I lose my ability to form words. Once I affect my parietal area, things like getting lost become more common with the visual spatial deficits. And then once I affect my frontal area, I lose the ability to have higher order thinking. And that can include things like having delusions, sleep-wake disturbances, a lot of apathy, and problems with emotional regulation. There's probably also issues with like planning, doing three-step commands. So there's a lot that goes on after you have that executive dysfunction. So as probably many of you probably know about who've interacted with anyone who has dementia, it's really difficult. And people lose their capabilities, they lose their independence. A lot of them become very fearful because they get lost as well if they can't remember where they're going. A hard part of the diagnosis, at least in the outpatient setting, is that driving becomes an issue. So you have someone whose family member comes in and says, hey, I think my dad or mom is having memory problems. And once you make that diagnosis of dementia, you actually have to take away their license. And again, that's a loss of independence for a lot of people. There are, of course, a lot of financial and caregiver burdens, and a lot of the cost is informal through caregivers who end up taking care of their loved ones. So it's a huge burden to the healthcare system and informally as well. So we'll continue with her case. Mrs. Smith ended up moving to a long-term care facility, and since then she's been living here for the past few months. She's been very aggressive since she's moved into a long-term care home, especially with bathing. And she wanders into other people's rooms looking for a cat truffle, which she's had for years. And these behaviors lead to difficulty for both staff and the residents. So it's just good pedagogy to review because it's getting late for you guys. So essentially take home so far, dementia has a lot of subtypes. Most common being Alzheimer's, and it leads to memory impairment, language and visual spatial dysfunction, and executive dysfunction. So have any of you guys heard about BPSD before? No? Okay, so it stands for Behavioral and Psychological Symptoms of Dementia, and essentially is just an overriding term for any behaviors or psychiatric symptoms that people with dementia might experience. And they come in clusters, as you can see the 6 clusters up there. The psychosis, things like delusions or being suspicious of everybody, thinking that someone's after them. I've heard stories or seen patients who think someone's tapping into their TV, or that they feel very unsafe even in their own home. Things like mania, they might feel like super happy, high energy all the time, or incredibly irritable. Aggression is kind of self-explanatory. Agitation, some of them might pace around a lot or a lot of repetitive actions, and depression with hopelessness and sadness, and apathy is also very common. So they'll become more withdrawn, socially withdrawn, and after that they become quite isolated. Whoops. So BPSD is quite complex, and there isn't a lot of good evidence yet as to why it occurs. So we think that it's an interplay between both biological and environmental factors, which essentially is a cop-out to say we don't really know yet. So in terms of the biological factors, there's the brain pathology itself, and we've talked about those clinical manifestations already at this point. There's also changes in neurotransmission once I affect the neurons themselves. And then for some people, all personalities are different. Colin here was probably more jolly than I would be. So if I had dementia, I'd probably be much more grumpy than Colin would be. And then other people's medical conditions that might predispose them to having, being more prone to having BPSD. And then in terms of the environmental factors, you can consider the full environment itself, as well as any life events that someone might have. So for example, such as being a war veteran. So I think the take home here is actually not about the pathophysiological mechanisms of BPSD, but more about that BPSD is a form of communication. So if you can kind of imagine, what would it feel like to you if I took away your ability to speak and I took away your ability to have any emotional regulation, but you were still able to remember the things that were important to you, such as family and friends. Um, can you imagine how you would communicate? And then kind of imagine how would you communicate if I didn't listen to anything you were trying to tell me through your form of communication? So the take home really is that for a person who has dementia, it might not be obvious what their behaviors, and sometimes the behaviors can be quite difficult for everyone that's involved. But kind of think of it as a way of them reacting to something that's going on, and that it's our job to investigate what that might be. So the BPSD algorithm is really straightforward. You kind of just go through an ABC approach. So for the antecedent, you kind of think about what happened before the behavior began. For behavior, being as specific as possible with what the behavior was, who it affected, and then the consequences, what happened next. And then from there on, we use what's called the pieces framework. Because everyone has, again, a lot of complex issues, and it becomes very difficult if you don't think about everything that can be involved with a patient. So for physical things, a lot of people have chronic pain, especially just as you get older. Things like osteoporosis, having fractures is really common. It's very common for them to be incontinent as well, so they can't control their pee or they'll urinate themselves, and that's a very uncomfortable feeling after you have a diaper. Things like being constipated is, again, very common for older adults. Intellectually, they might have issues with orientation. They might not remember what day or time it is, changes in their sleep routine. And if, like, for example, if I thought it was 2 a.m. and you woke me up, I'd probably be pretty angry as well. And that's exactly what happens when I get paged at 2 a.m. A lot of them might also have difficulty with finding words, and again, that form of communication can make us very frustrated. Emotional things, again, like losing their independence, losing their home, losing their spouse. Some people can get very isolated and not having their family come visit them, and that could take a significant emotional burden. And capabilities is very similar to that. I will take a side tangent on independence. At least there was at least one study that I remember previously that used. So they had like orchestras and had persons with dementia actually learn the music and play in an orchestra. So it's important that we remember that these older adults continue to have many skills that we might not be aware of. In terms of the environment themselves, things like noise, the design of the place, lights, or even smells can be very annoying to people, especially, again, if they're trying to sleep and we're not being mindful of it. And then finally, the social aspect of being isolated can cause people to react negatively. So some of you might consider at this point, like, where is the evidence to actually support this? Because there is an algorithm as well for the treatment of BPSD using pharmacological therapy. I don't think that's relevant for the talk today, but in the meta-analyses data, it actually shows that non-pharmacological approaches are equal to pharmacological approaches and have actually essentially zero side effects. So the non-pharmacological ones includes analysis-based interventions, which is that ABC and pieces approach. It includes music therapy and adequate pain management, whether or not that is pharmacological or non-pharmacological. And once you get into actual drugs to treat BPSD, it ends up being antipsychotic therapy. There are some studies that use cannabis as well, but I'm not super familiar with using it and how good it is or efficacious it is for the treatment of BPSD. Even antipsychotic therapy itself is not necessarily indicated. It's usually used for when there's severe agitation or delusions that can't be treated non-pharmacologically. So for the case resolution, I want you to actually turn to your neighbors for like a second so I can drink some water and hypothesize why Mrs. Smith may perhaps be having BPSD and how you would consider treating it. So review points, again, dementia is complex, has many types. Those with dementia can have BPSD, and we understand it as a form of communication. So we have to investigate the behavior, determine what caused it, and think about how we can treat it first, non-pharmacologically. So everyone's approach will be different, and all of you guys are right, no matter what it was. Even if you did nothing, I'm sure that's fine. So in terms of my case resolution, what I thought about is that, she's probably having a lot of pain whenever she needs to get undressed and washed, and we're probably not managing her. We might not be managing her pain appropriately once again with whatever reason she might have pain. So trying to think about that underlying cause. And some of you can kind of also imagine, like, how would you feel if you had someone different who was washing you every day when you had no idea who this person was, and essentially they're telling you, okay, it's time to get into the bathroom. They take off your clothes, and then they bathe you, and then they essentially throw you back into bed. That type of thing is actually probably very uncomfortable, and I like in terms of independence, it completely strips me of any independence, no pun intended. She probably wandering around her rooms again, looking for her cat, which her family's cared for or caring for after she moved to the long-term care facility. So what I do about this, again, having the least number of provider changes as possible. She might prefer someone more handsome like Colin Whaley as opposed to seeing myself every day. Uh, we can improve on her pain control, whether this is medical or not. Again, always preferring non-pharmacological first. And then things like, stuffed animals, pictures of her cat, making her room as homely as possible, and having care providers redirect once she starts wandering, because it could be a reality. So I'm just going to make a very quick tangent on technology and dementia. So the important part to remember in technology on dementia is that dementia starts, again, it's a disease, so it starts from assessment tools, diagnosis, and then maintenance of function. So you can think of ways that technology we can use in all of these methods, and there's for sure room in all of them. And again, I don't consider myself an expert at any of these. For assessments, some of them are going app-based for cognitive assessment tools. Some of you might have heard of like the mini mental status exam or the Montreal Assessment Scale. Those are this classic tools that are used for the diagnosis of dementia. They're essentially just tests that we use to assess for their memory, their ability to say things, their visuospatial sense, like drawing a clock. I'm sure like no one knows what a clock is anymore. So we all use digitalized versions. So that's now sort of being incorporated into assessment tools. In terms of other technological assessments, a lot of things are changing, right, in terms of what functionally is important to us. Things like making coffee or toast is probably not relevant to, or is more relevant to us as we get older, and less relevant to someone when these things might not have even existed. In terms of diagnosis, a huge place for large databases. It's things like identifying biomarkers, identifying disease response, looking at how different genetics may play a role in the treatment of dementia. And I'll just throw a tangent on, if you guys are not familiar with this, the Canadian Longitudinal Study of Aging looks into epidemiological data on Canadians, and there's a huge cohort of older adults who are part of this, and again, a huge amount of information that's available. Students are for sure able, as long as they have like a PI, to get access to this data in order to look into a lot of the physiology of aging. And then finally, for things like maintenance of function, you can look at coaching systems. There are things that have been done that include visual or verbal cues to persons who have dementia, and that can help them to walk through different procedures that might be hard. So remember, it's like 3-step tasks become harder once I start to lose my executive function. So things like washing their hands, or again, using other technological tools. There is maybe a role for smart homes, more in the sense of monitoring. So bath monitors or cooking monitors, helping with dressing might be helpful as well. GPS has been used for quite a while now, as like little wristbands that people can have on, and it will help for people, or more for their loved ones, to know where they are in the case that they get lost. And finally, socialization, like Pepper, having a robot that you can talk to, again, to help with issues with isolation, have also been used. So in terms of our conclusions, dementia is complicated. Alzheimer's is the most common type. BPSD is a form of communication, and it's important that it is hard for everybody involved, for the loved ones, friends and family, and sometimes it's really easy to forget the person who has the disease. So the takeaway from this is that we need to look for ways that we can bring back the aspects that make someone human with for people who have dementia, and that can be through communication assistance, that can be through memory aids, socialization, different things like, tapping into the talents that they continue to have that we might forget about. And it's okay to make mistakes. I make mistakes. There was a time when I had a patient who I was managing who had very severe dementia to the point where she was very delusional, thought that everyone was after her, locked herself in her home, that type of thing. So once the point when she was hospitalized, when we were actually able to provide care for her, and she had this heat bag because she used it for a lot of her back pain due to cancer, unfortunately, that was affecting her bones. So that heat bag cooled down. She was like, "Oh, I'd like to." And my heat bag's cool. I was like, "Oh, I'll warm this up for you, absolutely." So I take it and I put it in the microwave. Not sure how sterile that microwave is anymore. So I heat it up for her, and then I come back after a minute and I smell like this burning. And I'm like, oh, that's not good. So I accidentally left the heat bag was actually touching the metal plate of the microwave, and I burned through her homemade bag. So I just put it into another pillowcase and I gave it back to her. I obviously apologized, but she's never gonna remember that. And that's like essentially the end of it. I just walked away and said, you know what? I tried. This no bueno. So like I make mistakes. Uh, it's okay. We'll all make mistakes. Things are hard, but just remember that there's still a person behind it, and things will work out for the better. Does anyone any questions or concerns? It's essentially the end of my talk. Yeah, so I did my undergrad in Waterloo. I was in biomed. I think the great thing about Waterloo was the chance to create your own extracurriculars. Again, shameless plug for enTECH. And the fact that there's a lot, like it is actually a hub for a lot of things and a lot of places to get involved. I know the CLSA and some people also do work from Waterloo who are also involved with the Canadian Longitudinal Study of Aging. So I think it's a huge place if you're willing to look to get involved into things. And I would encourage everybody to just think about, just any interest at all. Find someone who can be a really good mentor to you. And that's essentially what I took into med school as well. So I went to Mac, which I think is also a great school. It's a huge research hub. And they also do a lot of work in like essentially everything and a lot of evidence-based medicine, which I think is incredibly important when it comes to providing a good standard of care for all patients. And there, again, I met incredible mentors. You'll find that if any of you are interested in geriatrics at all, that the geriatrician community is very small. It's very close-knit. Everyone is super friendly, and they're always willing to help you try to find that next thing that you're interested in. And it's not always something that has to be like research or any creating clubs and stuff. Sometimes it can just be very personal things like professional development, and that's what I encourage all of you to take that time to reflect on yourselves, like not trying to find what's important to you and where you can apply those skills, because all of you, I'm sure, work hard, have a lot of skills that you just have to be able to recognize and tap into. And then here I'm now in Calgary. Calgary's awesome as well. As you know, it's still, I think we have our Chinook, so it's now up to 8 degrees, but it was -20 yesterday, which is just wild. Again, the community is really nice. There's a lot of opportunity, again, if you're looking for it, to do things that you're interested in. So I'm still very open to a lot, and I think I would encourage you guys to do that as well. So whether that's in education, different advocacy forums, vulnerable populations, I'm still very open to these things and looking into where I might see myself in the future. So I hope that answers something.